All right, good morning, everyone. So today I'm going to talk about telenephrology and the case for ESRD remote care. So why this topic? Well, my original intention was actually to make the case for remote acute dialysis services through telenephrology. As you all may know, the Seattle VA does offer acute inpatient telenephrology services to the Seattle VA via tele-ICU platform. And I've been asked actually on multiple occasions if we would ever consider offering dialysis services remotely. And I thought this would be a good opportunity to explore this option. However, I soon found out that there are many companies offering this service, there's not a whole lot of data or published outcomes. But in my exploration, I did find an interesting story about remote ESRD care in more general terms. So let's get started. So after today's session, I hope that you all will be able to articulate the challenges of ESRD care to remote locations, as well as to appraise the impact of telenephrology on outcomes in ESRD. As well, to recognize how the COVID-19 pandemic has really catalyzed the development and use of telenephrology and the need for a new type of remote care. And then hopefully we can all conclude that telenephrology provides person-centered care for patients everywhere. So let's begin with the case. This is Mr. T. He is a 58-year-old African-American with end-stage renal disease due to secondary FSGS, presumed to be hypertension. He lives in a suburb of Seattle. He started peritoneal dialysis this year in July, and prior to initiating dialysis, he was not very engaged in his healthcare. But now his wife is helping, and he is doing well. They have limited time to take off work for their face-to-face visits. So will Mr. T benefit from telenephrology? Let's find out. All right, so before we get started, I'd like to define our terms. Here is the WHO definition of telehealth. And I would like us to consider telenephrology as a specialized form of telehealth, which really covers a more broad range of health-related services over telemedicine, which is really more of a direct private provider to patient direct connection via video conferencing technologies. Now, I especially like this last sentence. So telehealth, or we can say telenephrology, can contribute to achieving universal health coverage by improving access for patients to quality, cost-effective health services wherever they may be. And this is particularly valuable for those in remote areas and groups vulnerable and aging. All right, so today we will focus on telenephrology for the geographically remote to the more near, who either choose telenephrology because of their choice or because of their needs. All right, so let's begin with the remote ESRD patient. So a growing threat to specialty service care access for all patients, but especially those with ESRD in remote locations, is the shortage of new nephrologists. So here we have an ASN brief that gives us data about the nephrology match from 2009 through 2020 rather, our current year. And as you can see here, that generally speaking, offered positions have increased over time. There was a little dip here, whereas filled positions have dropped. And this is in the face of growing ESRD care. This is USRDS data through 2017. And as you can see, total ESRD is climbing. This is from the USRDS report from 2019. And other authors actually propose that by 2030, prevalent ESRD will likely be over 1 million patients. So taken together, this predicts a workforce shortage that will likely affect ESRD outcomes and ultimately be a barrier for ESRD care. Okay. So what's more, nephrologists practicing in the US tend to locate in or near urban centers, and this is likely due to the fact that that's where they train, and people like to stick around where they train. This is a map, and this is leaving multiple sort of rural areas underserved for nephrology care. This is a map from the nephrology workforce report from 2015. And tells us about the fellowship programs in red circles versus the ESRD patients per nephrology by hospital referral system. And as you can see, the lighter colors indicate less patients per nephrologist, where the darker colors are more. All right, and this is basically as of 2019, so likely things look, or 11, sorry, and likely things look even different. Okay, so what do we know about remote dwelling ESRD patients? So here are two studies that looked at survival outcomes, one looking at a Canadian PD population and the other a US hemodialysis population. So this Canadian study looked at incident PD over this time period and followed patients for a mean of 2.5 years. And they established distance from patient residence to the nephrology practice and found that adjusted death rates were higher in remote dwellers, basically everybody living more than 50 kilometers from the nephrology practice. This hemodialysis study is from USRDS data. Incident HD patients through this time period also established distance between patient residence by zip code and closest dialysis unit. And compared to the referent group, those living within 10 miles from the dialysis unit, the adjusted hazard ratio for death was really over 20% in the remote living group compared to the referent group. So can telenephrology help? Well, I think we already know the answer to that question, but let's take a look. So with this slide and the next, I'm going to present outcomes on patients from outside the US. Historically, the use of telenephrology in the US has been limited by regulatory issues as well as reimbursement. So there's really limited data. So here's some outcomes on telenephrology and PD. This is an Italian study out of Venice. They looked at the use of automated peritoneal dialysis plus remote patient monitoring. And for those of you that don't know what remote patient monitoring is with automated PD, basically patients and providers have access to a secure web. Patient enters information, and then this data information is viewable real time by providers, and we can make adjustments as needed without actually having to see the patient in person. So these patients were compared with use of APD without remote patient monitoring, and patients were looked at over a 12-month period, and improved outcomes were found with remote patient monitoring exposure. Here are some of their outcomes. Though there were more prescriptions, so the remote patient monitoring with APD is in green here, and the PD alone is in red. So RPM, or remote patient monitoring exposure, was associated with more prescription changes, not surprisingly, less patient drop-off, less hospitalizations, time savings, as well as money savings. These two other studies out of Colombia and Spain found similar findings. Let's see here. With incident PD patients using remote patient monitoring software. They found less hospitalization, less hospital days. This is an earlier study prior to the advent of remote patient monitoring. And this group found that video visits actually had improved outcomes over face-to-face visits, as well as, and specifically less hospitalizations, time savings, similar costs, right? So concerns about cost upfront were not found, as well as an improved subjective quality of care. Here are a couple studies looking at hemodialysis outcomes with telenephrology. This is one looking at the use of telenephrology in the remote Pacific Islands far off the coast of Australia, and they compared face-to-face visits on their main island versus a video teleconferencing system on a remote island, and looked at dialysis adequacy and survival over 6 years, and found no difference in the group. So the telenephrology option was non-inferior. This is a study out of Canada, specifically Manitoba. They also looked at urban versus remote hemodialysis care. And in this case, also an earlier study, their telenephrology care was via weekly telephone conversations, and they looked at both short and long-term survival and found that the remotely delivered care via the telephone conversations, survival was better in that patient population versus urban. Okay. So what about telenephrology ESRD outcomes in the US? Well, as I said, there were regulatory limitations, but that all changed, or rather it changed significantly with the signing of the Bipartisan Budget Act in 2018, and specifically though for home dialysis patients. CMS now allowed patients on home dialysis to choose to have their monthly visits through telehealth from home. And previously, the site visit was limited to facilities in remote or underserved areas. However, there were still ongoing limitations. Telehealth was only available after the first 3 months of patient care, and prior to that, face-to-face visits were required, and then face-to-face visits were required at least quarterly going forward. Nonetheless, this was a major change. The ability to provide remote care for home dialysis patients wherever they lived was now an option. But were patients interested? So here's some data on specifically PD interest and outcomes. There's really not a whole lot on home hemodialysis in this era, at least that I can find. And what really started to take hold was this remote monitoring, this capability to remotely monitor, specifically folks on APD, as opposed to really sort of video visits as an option for their monthly visit. Okay. So this is a study looking at interest out of an urban population in Washington, D.C. About 30 patients were surveyed, and there were varying results based on specific questions related to telehealth, or we can say telenephrology. But the survey did find that the vast majority of patients were interested. All right. This is a study out of the mid-Atlantic states where they compared remote patient monitoring, specifically weight, blood pressure monitoring, as well as video conferencing in both APD and CAPD, and found that there was overall less costs and hospitalizations with remote patient monitoring exposure. This is another study out of Massachusetts. Frequent users with remote patient monitoring has also had less hospitalization, shorter length of stay, less technique failures when compared to non-users. All right, so there's interest and positive outcomes, as well regulatory changes that are setting the stage for increased use for telenephrology, especially in the home population. But many authors were concerned because telenephrology was not really taking off. And then this happened, right? So suddenly there was a need for a new type of remote care. Now the use of telemedicine has exploded, and programs have been developed almost overnight, as well as adopted, and for the use of a new type of remote care to both protect patients and providers. Now, data on the use of telenephrology or telemedicine, more specifically, or rather, reverse that, during this pandemic has been so far mostly descriptive. However, I feel like we can move forward with confidence given the positive outcomes in other remote conditions. Okay. So in response to the healthcare crisis, CMS expanded the use of telehealth with the 1135 waivers. Specifically, any patient anywhere really could use telehealth, no longer restrictions to just home dialysis or the remote or the rural or underserved areas. New as well as follow-up services could be paid for. In several interests, there was dropping of co-pays. Patients were able to bill for services outside of the state. So what do I want to say, privileges were made by proxy, and really anybody could use telehealth, not just primary providers. Phone visits were also included in telenephrology technologies, whereas previously they had not been. So things changed, really opened up the ability for us to use telenephrology for the care of our patients. All right. So what has the COVID-19 telenephrology experience been like so far? Well, you all likely have both positive and negative experiences that you could share. And there have been several published reports, again, mostly descriptive, but here's one out of New York City that I thought was reflective really of our shared experience, and they described their home dialysis population, including both PD as well as home hemodialysis. They offered telehealth visits to all of their patients. Several patients actually did not, what do I want to say, agree. But they found that those that did opt for telehealth visits, both the remote patient monitoring as well as video visits, that there were several advantages, right? That we could now socially distance effectively, there was still continuity of care, and patients were very happy. Some of the drawbacks were that blood draws were more challenging. So again, I think that's a shared experience that we all have. So what guidance is there out there? What are the experts saying? And what are we learning from our own experiences and the best way to care for our ESRD patients? So here's some thoughts in the specifically outpatient arena. So encouraging home dialysis, right? This is a big push for the Advancing American Kidney Health Initiative, but this is now, and as well, this has been featured in a recent New York Times article. But now this even seemed more exciting, right? Because we could offer social distancing to our patients and keeping our vulnerable population safe. We, our own home dialysis program, it is growing. I can't say is it really expanded exponentially in the COVID era, but perhaps. Virtual visits for our PD patients, for all our PD and home hemodialysis patients, and even in-center dialysis patients. So as far as PD, our personal experience at the VA, basically close to nearly 100% of our patients are offered, well, everybody's offered a telenephrology visit. Most agree. We do have patients in seen face-to-face and in some circumstances. But really, I would say almost 100% of our patients are being monitored by telenephrology. We do not have home hemo patients, so I can't comment on that. Choosing remote monitoring for home patients, this is something that we are doing, I think, with nearly 100% of our dialysis patients that are on APD. As far as the in-center hemodialysis, I forgot to mention, I know that Northwest Kidney Centers set that up and offered it widely. Certainly earlier on in the pandemic, there was majority of folks were offering that sort of service. It sounds like numbers have trailed down some, but there are still many folks that are using that option. Virtual visits with other providers while on dialysis. Myself, I had an experience with one of my patients recently, actually just Wednesday of this week. He needed to follow up with his neuropsychologist regarding some recent testing. He wanted me there, and so what I did was I was able to set up the WOW that we use, the workstation on wheels, right, with a camera. Set up a video conference between the three of us, and we were able to have the meeting while he was on dialysis. So that really would have never happened before. So that was exciting. Virtual education of both patients and providers. providers. That's happening now, right? At the VA as well, we have our VA ECHO program that's been going on for years and years and has been going strong. As far as virtual education, we're working on getting that set up for our patients. All right. What about inpatient experience? So I think, you know, a good approach would be to begin with outpatient telenephrology in a way to limit infection risk. Using virtual rounding, we're all familiar with what that means. This certainly helps to limit health provider exposure and illness and preserve our workforce, as well as preserving precious PPE. Use of asynchronous electronic consults, even in the inpatient arena, for those remote as well as near. So this is, you know, what we've been doing with the Spokane VA. And even I would say consider the development of an acute nephrology care for remote hospitals, right? In the beginning, I began saying that's sort of what I had intended to talk about, but didn't see a lot of data. But what do we know about acute telenephrology care for remote hospitals? So this is a perspective from June, I believe, in Kidney 360 from Janice Leah et al. Out of Emory, and she describes the experience of their acute telenephrology experience, specifically through the Emory Telenephrology program. They are an alliance or association with a company by the name of Sanderling Renal Services. And there are many companies like Sanderling that basically help to offer and set up remote dialysis care for patients in rural hospitals. In this case, two of the spots that they had their services was in Bainbridge, Georgia, down here, and I think this is Hawkinsville. All right. So through their program, they offered ESRD, AKI, and CKD consults. They used FaceTime specifically, as well as the Littman electronic stethoscope. And for their dialysis services specifically, so they had a dialysis tech on site. And that was the only person that was on site. Everybody else was remote. So the hemodialysis nurse, the nephrologists were all remote. But they also used a web-based software, right? So the tech would enter the information into the flow sheets, and that information was available real time for the other providers. There was also a setup for sort of any sort of data that appeared outside of the set range. They use the Next Stage system, the System 1S, which is a home system. So really very user-friendly, the tech easily able to monitor. Of course, the tech was not alone. They had the floor nurse, right, also involved in the care. So the floor nurse was able to follow the patient and continue to follow the patient through their dialysis services. They saw both ICU as well as floor patients. I think about a third of their patients were ICU. This is a little bit of information on their characteristics as well as outcomes. Again, there was really no comparative group. This is mainly just sort of a descriptive piece. So their end-stage kidney disease, their length of stay was really not that long. I find that's actually kind of surprising. Few transfers, less transfers certainly than the non-ESKD, ESKD. And with their dialysis population, zero mortality. They had a total of 158 sessions. Number of sessions per admission actually wasn't much, so these patients probably weren't all that sick. They also found that there were few complications, not a lot of hypotension, which I actually find somewhat interesting. And Dr. Leah proposes as well that this program may be a way of reducing disease transmission by keeping patients sort of in their original site, not having them transferred elsewhere, say into Atlanta for dialysis. And so offloading some of the stretch resources that could be occurring and will continue to incur in our COVID crisis. All right. So let's get back to Mr. T. So he gave, and Mrs. T. So they both gave me permission to share their photo, as did Davi, our PD nurse, and Dr. Barkin. So hopefully there's no regrets at this time. So here we are using VA Video Connect, which is our video conferencing platform. We're having a monthly visit. Mr. T and his wife are currently at home, but really they could be anywhere, right? Mrs. T works at home, Mr. T doesn't. We did actually try or plan to have Mr. T at work and Mrs. T at home on one occasion, but there were sort of connectivity issues there. So he actually, on that particular visit, he opted to come in. But we certainly could do that, and that's an option for this patient. So Mr. T utilizes the Baxter AMIA, and he inputs his information. We, myself and Davi, are able to visualize this information real time, make changes, contact the patient, and really tailor his care in a way that that benefits him. So what else? Oops. So as you can see, they're happy, right? I didn't ask them to smile. They smiled on their own. But they're avoiding time off work, right? They're at home, they're avoiding travel costs, and they're still able to see their provider. So it's a win-win. So here we are offering quality, person-centered care via telenephrology. All right. So in summary, telenephrology is an effective tool to improve care of all ESRD patients, both near and far. Government policy changes and a healthcare crisis have really opened the door for ongoing telenephrology use and development. And telenephrology provides care that keeps patient preferences and safety at the forefront. All right, and with that, I will finish. Questions, comments?
Thank you so much, Dr. Fleet, for an extremely timely talk. And we can open it up for a few minutes for questions here and invite people to either write me via the chat or to use the raise your hand function. I'm seeing one question from Arthur. So telephone only visits currently do not fulfill the MCP criteria for our ESRD patients. How does CMS reconcile the disparity this creates with those folks on home dialysis with less resources who may be unable to do the video portion? I don't know if you, obviously within the VA system, there are separate issues, but I'm curious what your thoughts are.
Yeah, I mean, I think that's certainly one of the commentaries and criticisms of telenephrology, right? And telehealth in general is that these technologies are not available are not necessarily readily available to all, right? And certainly it does favor those who are more tech savvy and have the ability to have a good internet connection, etc. So, some of the proposals are, well, do we offer, do we basically give our folks technology? So that's one option. It's also so, I mean, I think it's a problem, certainly. I also find that some folks are just simply not interested in televisits, right? I think many of our providers at the VA have found that to be the case, that all the cajoling that we do, patients are just not interested. They tell us that they're not computer people. They don't even have a smartphone. So it is certainly an issue. I think, we'll just have to see. We don't know. Maybe things will change in terms of the CMS reimbursement strategies, I think. But that is a concern. At the VA currently, we are able to get full RVU generation. So, but I think that certainly is going to differ across platforms.
And maybe as a final question before we move on, Brendan asks, do you have any anecdotes about physical exam methods?
Yeah. Well, I find with our PD patients, right, I find the patients are able to kind of change the view of their camera so that we can see their belly. We do not have any of this electronic microscope or stethoscope technology. And that would be difficult, right, when going into patients' homes. But I think, you know, personally, though I appreciate the physical exam, I think we can get a lot by just simply looking at the patient and kind of sensing how they are and asking them. So being creative, I guess, is what I've done so far and found that to be effective. And certainly if there's any questions, then those patients need to come in for a face-to-face. So it doesn't satisfy everybody's needs.
Right. Well, thank you so much, Maggie, for a great talk, timely talk, and I'm sure we could go on to talk for another half hour about this, but thank you so much.